Hello everyone in CardioMinds channel and welcome to a new specific disease that is responsible for ventricular arrhythmias, which is dilated cardiomyopathy we are going to speak about today. We remember this famous diagram, and regarding dilated cardiomyopathy, the predominant type is the monomorphic VT, as here the mechanism is a scar-related reentry, so monomorphic is much more common than polymorphic VT. The definition of dilated cardiomyopathy is that it is LV dilatation and systolic dysfunction unexplained by coronary artery disease or abnormal losing condition. So it is not ischemic, not due to valvular heart disease. Regarding its prognosis in adults, it showed 1-year mortality of 20 to 25% and 50% survival at 5 years, and sudden cardiac death may occur in up to 12% of patients with dilated cardiomyopathy and still accounts for 25 to 35% of all death. In children, the prognosis is poor, with a 5-year incidence of heart transplantation or heart failure related death of 40%, a higher percentage than in adults. However, the incidence of sudden cardiac death in pediatric dilated cardiomyopathy patients is much lower, with a 5-year incidence of 2.4 to 3%, as reported in 2 large pediatric cardiomyopathy registries from USA and Australia. So the incidence of pump failure is higher in children, but the risk of sudden cardiac death is lower than adults. We usually divide the causes of dilated cardiomyopathy into being genetic causes versus acquired causes, but genetic predisposition may interact with extrinsic factors like peripartum, duration, alcoholic cardiomyopathy, or chemotherapy-related cardiomyopathy, so sometimes both factors interact together. And the phenotype can change with time, and so it may not meet the standard criteria at the time of disease manifestation. This resulted in the invention of this new terminology called Hypokinetic Non-Dilated Cardiomyopathy, which is impaired LV systolic function without dilated dimensions. So it may represent an earlier stage than the frank dilated cardiomyopathy. As we can see in this example, that the patient in sinus rhythm shows small amplitude P waves with first-degree AV block, which may occur in specific genetic diseases that may cause dilated cardiomyopathy that we are going to speak about later. And here the ECG during VT showed inferior axis, suggesting an LV summit origin. And as we see in the cardiac MRI with gadolinium, there is mid-wall septal late gadolinium enhancement due to scarring in this anatomical region. So how can we diagnose dilated cardiomyopathy? First of all, you should start with ECG to show you the rhythm, whether it is sinus atrial fibrillation versus incessant atrial tachycardia or slow VT that may be a result or may be a cause of tachycardia-induced cardiomyopathy rather than dilated cardiomyopathy, showing conduction abnormalities like first-degree AV block or sometimes higher grades AV blocks, showing whether the patient has left bundle branch block or non-left bundle like right bundle or intraventricular conduction delay. The next step would be the echocardiography to assess the LV systolic and diastolic function, measuring the LV dimensions, measuring the wall thickness plus minus if there is any evidence of infiltrative pathology, exclude any primary valvular disease that may be the cause of LV dysfunction rather than dilated cardiomyopathy, and detect whether there is any secondary valvular disease like secondary mitral regurgitation. And of course, we should not forget to assess the RV function and dimension, as here the LV dysfunction is the most common cause of pulmonary hypertension. Then we come to a more complex investigation, which is cardiac MRI with gadolinium. In this famous paper regarding the late gadolinium enhancement, which is an indicator of the extent of scarring and the risk for ventricular arrhythmias or sudden death in dilated cardiomyopathy, the late gadolinium enhancement was strongly and independently associated with the risk of ventricular arrhythmias or sudden cardiac death, and still this association remains significant in those with ejection fraction more than 35%. This results in this recommendation in the 2022 guidelines that the CMR with late gadolinium enhancement is class 2A to be considered in patients with dilated cardiomyopathy or hypokinetic non-dilated cardiomyopathy to assess the etiology and the risk for ventricular arrhythmias and sudden cardiac death. Now it's time to think of genetic testing, as its yield is very high in patients with dilated cardiomyopathy if they are having familial forms, like having positive family history of LV dysfunction or heart failure, history of sudden cardiac death in a first-degree relative at younger age, presentation of the manifestations of heart failure at young age, signs suspicious for a specific etiology like prolonged AV conduction for patients with lamin gene mutation. These pathogenic mutations can be identified in 25 to 55% of dilated patients, most often with autosomal dominant inheritance. So here genetic testing is essential. Examples of the famous genetic mutations that may result in dilated cardiomyopathy: the titin gene mutation that is the most frequently found, lamin AC mutations that we sometimes call laminopathies, sarcomeric gene mutations that may result in dilated or sometimes hypertrophic cardiomyopathies, desmosomal gene mutations that sometimes we call desmopathies, phospholambin gene mutation, RNA binding motif protein 20, and filament C genetic mutation. Keep a note that the carriers of desmosomal and lamin gene mutation experience the highest risk of ventricular arrhythmias independently of the LV ejection fraction. That's why it is important to detect these highly pathogenic genetic mutations. So the recommendation to perform genetic testing including at least lamin gene, phospholambin, RNA binding protein, and filament gene mutations in patients with dilated or hypokinetic non-dilated cardiomyopathy if they are having AV conduction delay at age less than 50 years, family history of heart failure or sudden cardiac death in a first-degree relative at age less than 50 years, and class 2A in patients who present at young age or having signs suspicious for an inherited etiology. Do we need to screen the relatives of a patient with dilated or hypokinetic non-dilated cardiomyopathy? Yes, of course. In first-degree relatives, we should perform an ECG and echo at least if the index patient was diagnosed at age less than 50 years or having clinical features suggestive of an inherited cause, or there is family history of the disease or premature unexpected sudden death. If it was a sporadic case, so ECG and echo for the first-degree relatives is just class 2B. So according to these diagnostic tools, we could perform risk stratification to divide the patient whether he is low risk or high risk, according to the NIHA class, LV ejection fraction, percentage of late gadolinium enhancement, type of genetic mutation, and presence or absence of unexplained syncope, which of course needs programmed electrical stimulation using an EP study to determine the cause. All of these risk markers are considered risk for all-cause mortality. Let's now move to the treatment of the ventricular arrhythmias in dilated cardiomyopathy patients. We are not speaking about the treatment of dilated cardiomyopathy, but the treatment of ventricular arrhythmias per se. Reminding ourselves that we need to watch this video regarding the indications of ICD in heart failure patient, which is present in an English and Arabic versions, which is part of the 2021 guidelines of heart failure. In brief, we remember when we made this comparison of ischemic versus non-ischemic etiology, as we mentioned that patients with ischemic heart disease are at greater risk for scar-related ventricular arrhythmias and so greater risk of sudden cardiac death. Therefore, the benefit of ICD is greater in patients with ischemic heart disease in comparison with non-ischemic cardiomyopathy. When do we need ICD? In patients after a minimum of 3 months of optimized medical treatment if it failed to increase the LV ejection fraction to more than 35%, including the use of class 1 recommended drugs for heart failure with reduced ejection fraction. From 2002 to 2005, there were famous 5 trials regarding the ICD in those patients, and a meta-analysis of the 5 trials demonstrated a 31% reduction in the all-cause mortality with ICD in relation to optimized medical treatment. But we have the great obstacle, the DANISH trial, which showed that the rates of sudden cardiac death were low in patients with non-ischemic cardiomyopathy, as only 70 patients out of the large number of more than 1,000 patients followed up over 5 years had sudden death, and there was no reduction in the primary endpoint of all-cause death for those patients randomized to ICD, despite a significant reduction in the sudden cardiac death in the ICD group, which raised a question mark about the indication of ICD in dilated cardiomyopathy. However, a subgroup analysis suggested that there was a benefit in patients less than 70 years in compared to older patients, and a recent meta-analysis of 6 primary prevention trials in non-ischemic cardiomyopathy still showed a reduction in overall mortality with a survival benefit with ICD, although the effect was significantly weakened, of course, by the inclusion of the DANISH trial in the meta-analysis. There are some potential explanations to the results of the DANISH trial, that there was a low sudden cardiac death rate in the trial, which was 4.3 in the ICD group and 8.2% in the control group, and the excellent medical treatment that those patients received, in addition to the high prevalence of CRT. This may explain why the benefit of ICD was lower in dilated cardiomyopathy. So in the 2021 guidelines for heart failure, the primary prevention ICD should be considered to reduce the risk of sudden death and all-cause mortality in patients with symptomatic heart failure, NIHA class 2 to 3, non-ischemic etiology, ejection fraction less than 35%, despite 3 months of optimized medical treatment, provided they are expected to survive longer than 1 year, and this is class 2A in non-ischemic LV dysfunction. What about the 2021 guidelines for ventricular arrhythmias? The primary prevention ICD is nearly the same in symptomatic heart failure, ejection fraction less than 35, and 3 months or more of optimized medical treatment. But there is an additional indication. The patient with ejection fraction less than 50%, so we may consider them in the mildly reduced ejection fraction range with 2 or more risk factors like syncope, late gadolinium enhancement, inducible sustained monomorphic VT during EP study, or detection of a pathogenic mutation. Here the patient has a class 2A to put an ICD. So here you don't need to have an ejection fraction less than 35% to put an ICD. Just the presence of 2 of these risk factors is an indication to put an ICD if the ejection fraction is less than 50%. If the patient is having syncopal attacks and is unexplained after non-invasive evaluation, we should have an EP study to perform programmed electrical stimulation. If there is inducible sustained monomorphic VT, go for ICD. No inducible VT, no need for ICD. The same steps that we have performed in patients with coronary artery disease with unexplained syncope. And according to literature, the patients with dilated cardiomyopathy with ejection fraction more than 40%, they are having mildly reduced ejection fraction. And unexplained syncope with ICD implantation after a positive results of EP study, 80% had appropriate ICD therapy during follow-up. This means that they had benefit from ICD, and no sudden cardiac death or symptomatic VT occurred in those with no inducible VT in programmed electrical stimulation. When we ask this question about the patient with mildly reduced or preserved ejection fraction in ischemic LV dysfunction, we mentioned that there are no data to support primary prophylactic ICD implantation in post-MI patients with preserved or mildly reduced ejection fraction. Regarding dilated cardiomyopathy, the prospective studies evaluating the benefit of ICD in those patients, but they are having risk factors that have been associated with ventricular arrhythmias and sudden cardiac death are still lacking, so there are no strong or valid recommendations in those category of patients. And due to the limitation of ejection fraction as the only risk factors in dilated or hypokinetic non-dilated cardiomyopathy, the panel of guidelines in 2022 shares the opinion that in presence of a combination of risk markers that mentioned before, an ICD should be considered. Now we are moving to a specific subtype of dilated cardiomyopathy, which are laminopathies. Those patients having lamin gene mutation represent 5 to 10% of the whole patients, usually associated with early incidence of atrial and ventricular arrhythmias, premature conduction disease, high risk of sudden cardiac death, high risk of progression to end-stage heart failure, and the risk predictors of ventricular arrhythmias in those patients are the male sex, ejection fraction less than 45%, presence of non-sustained VT or presence of AV block in ECG, and presence of non-missense mutation using genetic testing. There is a risk calculator to calculate the risk of life-threatening ventricular arrhythmias at 5 years. According to this risk calculator, the ICD implantation should be considered in dilated cardiomyopathy patients, so they are having manifest cardiac phenotype, if they are having detected gene mutation of the lamin gene mutation, if the estimated 5-year risk is more than 10%, plus presence of non-sustained VT, or ejection fraction less than 50%, or presence of AV conduction delay. So a high risk plus one of these risk factors is an indication to put an ICD. And the big no that those patients should be prohibited from high intensity exercise, including competitive sports, for those with lamin gene mutation due to the higher risk of exercise-induced ventricular arrhythmias and sudden cardiac death. Back to the 2021 guidelines of heart failure, the secondary prevention ICD was indicated in patients who recovered from ventricular arrhythmias causing hemodynamic instability, who are expected to survive for more than 1 year with good functional status in absence of reversible cause, unless the ventricular arrhythmias occurred in the first 48 hours after MI. What about the 2022 guidelines of ventricular arrhythmias? ICD is still indicated as class 1 in those who survived sudden cardiac arrest due to VF, pulseless VT, or hemodynamically non-tolerated VT, and class 2A in patients who have hemodynamically tolerated sustained monomorphic VT. So presence of ventricular arrhythmias in those patients is still an indication for ICD implantation. Those patients may benefit from oral amiodarone or replacing beta blockers by sotalol if they are experiencing recurrent symptomatic ventricular arrhythmias despite optimal ICD programming and beta blocker treatment. According to the OPTIC trial, 412 patients with ICD within 21 days of VT or VF were randomized to amiodarone plus beta blockers, in which the rates of ICD shocks were 10.3%. Sotalol alone, here the rate was higher, 24.3%, and beta blockers alone rate was much higher, 38.5%. So the lowest risk for ICD shock was the combination of amiodarone with beta blockers. Some patients may need catheter ablation if they are having recurrent symptomatic sustained monomorphic VT or ICD shocks. For sustained monomorphic VT, if the antiarrhythmics are ineffective, contraindicated, or not tolerated. And the outcome here has been reported to be similar for those with coronary artery disease and dilated cardiomyopathy. However, VT recurrence rates are usually higher in dilated cardiomyopathy patients in comparison to coronary artery disease patients. Here, the epicardial approach is needed in about 27 to 30% due to presence of subepicardial scars in dilated cardiomyopathy, and endocardial voltage mapping here is usually negative, in contrary to the ischemic patients in which the scars are usually subendocardial or transmural. And bailout strategy, including transcoronary, ethanol ablation, or bipolar ablation, or even surgical ablation, may be required in those with laminopathies or deep intramural or anteroseptal substrate locations of scars. This diagram shows how to manage a patient with dilated or hypokinetic non-dilated cardiomyopathy. CMR, as we mentioned, is class 2A if there is a suspicion of a cause requiring specific treatment, so we need to go to the specific sections for specific diseases that may result in LV dysfunction, like inflammatory disease. If there are no evidence for a specific disease, so we need to look for one of these risk factors that raise a suspicion for a genetic cause. If there is evidence, so go for genetic testing as class 1. No evidence for these risk factors, still genetic testing is indicated. We need to detect if there is evidence of the pathogenic lamin gene mutation, and according to this we calculate the 5-year risk of ventricular arrhythmias if it is more than or equal 10% and ejection fraction less than 50, or non-sustained VT or AV conduction delay. Go for ICD implantation if there is no evidence, just annual re-evaluation. Then we need to assess the LV ejection fraction. If it is less than 35%, ICD for primary prevention is indicated. More than 35% up to 50%, we need to detect if there is evidence of 2 or more risk factors that we mentioned before. If there is evidence, so ICD implantation is indicated, like presence of syncopal attacks, non-sustained VT or inducible VT in EP study, or genetic mutation. If there is no risk factors but the patient has unexplained syncope, go for EP study and programmed electrical stimulation to decide the need for ICD. No evidence of inducible VT, implantable loop recorder is indicated. No any other risk factors, so just go for follow-up and starting, of course, the heart failure treatment medications. So we have reached the end of our video today, and our important take-home message that genetic testing and cardiac MRI can be essential tools in those patients with dilated cardiomyopathy for both risk stratification and deciding the most appropriate treatment modalities to reduce the risk of sudden cardiac death, especially whether this patient would need ICD or not. Thank you very much for watching this video, and I advise you to check the reference in the description below the video and wait next week for another specific disease causing ventricular arrhythmias.